So this is a case of Dr. Weintraub's, and these are the chromosomal abnormalities. As you can see, there are numerous chromosomal abnormalities. This is typical for solid tumor, and like hematologic diseases, we see a lot of chromosomal abnormalities. And you can really see from the color or the intensity of the colors that on chromosome 8, for example, most likely there are some genes which are amplified, and we need really to point out these genes. So if you go to the next slide, please. We use our second software that look at individual genes. So if for this particular patient, we see amplification in ERB-B2, which is the HER2 genes. We see also amplification in TOP2A, and we see also amplifications on chromosome 8 for the MYC and RAD21 genes. Next slides. Now, when we look at the expression profiling, and remember what I mentioned in previous, whoever attended the previous report, we use our artificial intelligence for classifications of the disease. So this automatically told us, as you can see with the circle, it's breast cancer. So this is the breast cancer based on the expression profiling. And this allows us to look at the expression levels in various breast cancer. So as you can see, we can sort them on the left panels, which genes is expressed, and this calculate between the breast cancer, how many folds the abnormal expression we see in the RNA. This is extremely important because, as you know, each cancer will have a different expression profile. What you want to look at, what's distinguish today's, let me say, breast cancer from the other breast cancers that we saw yesterday as comparison. So, for example, in this incidence, the MYC gene is way higher than average breast cancer. And as we go on, I'll show you more cases like this. Next slide. But my purpose of this particular case is to point out that this case actually it has overexpression of ERB2, and it has gene amplifications, as you saw. But in addition to that, it has a mutation in ERB2 or HER2 genes. So this is like very interesting because it has a mutation, and the mutation is at amino acid, as you can really see it here, 778. And at the same time, it has the gene amplification. And one of the questions for Dr. Weintraub's, how he will consider this, use antibody versus the kinase inhibitors. And the other things which is very important, and I want to, as highlighted in red and bold, is this genes which has a mutation, the BDC1LG2. This is a long name for BDL2 gene. You know, we are all familiar with BDL1 genes, and when it is overexpressed and for immunotherapies, very few people, also everybody thinks that it is relevant, but because it is very difficult to analyze by immunohistochemistry, that BDL2 is very important gene, and this particular case has a mutation in this gene. But on top of that, as you can see in green, this patient has high TMB because it is a 12, and our cutoff for the TMB, which I really should mention, in solid tumors, we always calculate the TMB, tumor mutation burden. It's very important for immunotherapy, and we calculate the microsatellite instability. in our panel for the solid tumors of 434 genes, we calculate the microsatellite instability based on almost 190 different markers. So this particular patient, as you can see, the score for microsatellite instability as shown in green is 27.4, which is way below our cutoff point for instabilities. But this patient has TMB high. And as you can really see, this particular patient has also mutation in the estrogen receptor, the ESR1. That's the estrogen receptor. So this patient is very complicated from this point of view in terms of making decision how to treat this patient and with all these abnormalities. Next slides. This is just to mention, that it has been reported for the ERBB2 mutations as present in de novo, which is very important. Unlike the estrogen receptor mutations, almost always the estrogen receptor mutation are after treatment with hormonal therapies. You see mutation. Unlike the ERBB2 mutation, currently the literature, most of the literature says that you see them in de novo in patients. And this particular patient has his mutation in the tyrosine kinase domains, so it must be important mutations. Next slide. So this is the summary, on this patient. So definitely has the ERBB2 or the HER2 gene amplified and mutated, has BDL2 mutations, as well as the high TMB, and at the same time has the estrogen receptor, in particular the estrogen receptor mutation in this patient. And I'll stop here and ask Dr. Weintraub to comment on this. And actually, I have more question for him, but let's start with Dr. Weintraub. Dr. Weintraub?
This is an incredibly interesting case because it totally manifests the issue of clonal heterogeneity. It's a patient who's 54, original breast tumor was ER/PR positive, HER2 negative, but her original liver biopsy, as she presented with liver mets back in 2014, was triple positive. ER positive, PR positive, and she was FISH positive for HER2 new. So she was treated with anti-HER2 new drugs and anti-hormonal therapy. As time evolved, she developed, of course, resistance to aromatase inhibitors, as would have been predicted by the ESR1 gene. A repeat liver biopsy was done, and that's what Dr. Albertar is showing you now. It's a 6-year interval. This liver biopsy is HER2 negative by IHC and FISH. So this patient, because she had repeat genomic next-gen sequencing, we learned the following. 1, she really is ERBB2 positive and should respond to anti-HER2 new therapy. 2, she's ESR1 mutation positive, so she should be resistant to aromatase inhibitors as she was, and should have had some response to fulvestrant. 3, we're seeing a lot of patients that are ERBB2 positive that are also expressing high TMB or PDL1. And we now know that there's a synergism with anti-HER2 new drugs and anti-PD1 drugs in patients like this. So this is a patient that's doing very well now on Abraxane, trastuzumab, pertuzumab, and immunotherapy, utilizing all of the targets Dr. Albertar pointed out.
So one point which is very interesting, I don't mean to get into controversy, but the immunohistochemistry and the fish, you didn't really detect the overexpression of the ERB2. And my expectation, because the amplification is not that high, but no questions in my mind, there is a adequate amplification, and we can quantify the copy number. And I think these information are important, but on top of that, with the mutation, is very important. So my question to you, Dr. Weintraub, when do you think like using the antibodies for the RBP2 in this patient is wiser than using kinase inhibitors for the RBP2?
Well, it's very interesting because this patient was on anti-IV extracellular HER2 blockers, but because of what you found, she probably would do well with TKI inhibitors like neratinib, lapatinib, or tucatinib. So your ERBB2 gene amplification RNA overexpression would indicate that she should do well with a TKI inhibitor.
Okay.